Good evening, everyone, and welcome to the 8th edition of the Jaipur Surgical Tutorial Masterclass. For those who are joining us for the first time, Jaipur Surgical Tutorial, JST as we call it, is an online education portal started by us at the Mahatma Gandhi Medical College and Hospital in Jaipur in India. This is done every Saturday, 9 to 10 a.m. India time. In between, I will project a slide which will give details as to how you can join Jaipur Surgical Tutorial, those who are joining for the first time. In addition to those weekly 1-hour sessions on Saturday morning, for the last 8 months, we've been conducting this monthly masterclass, which is done on Thursday and Friday, last Thursday and Friday of a month, 7 to 9 p.m. A single theme, which is covered in 2 days, 4 presentations of 30 minutes each, covering some aspects of the theme. Jaipur Surgical Tutorial has been looked after by my colleague, Dr. Anand Nagar, who is an associate professor of HPB surgery at my institution. And technical support is provided by Dr. Avinash Tak of Dwarika Hospital, Ahmedabad, one of my former fellows from SCPGI, and his team of Himanshi and Kripa. Before we start, 2 small announcements. One, due to some personal commitments, I may not be present throughout the masterclass. So I have requested Dr. Deepak Govil, who is one of the senior consultants in surgical gastroenterology at Apollo Indraprastha Hospital in New Delhi. He will be moderating this session. The second is that the first talk, which was to be by Dr. Vinay Mahala, again my colleague here at Mahatma Gandhi Hospital, he had to rush to theatre to explore a patient with bleeding. So in case he is able to join by 8:30, his part will be presented at that time. Otherwise, Dr. Jayanthi Venkataraman, who's one of the senior consultants in gastroenterology at Gleneagles Hospital in Chennai, she has very kindly agreed to cover that part also on behalf of Vinay Mahala in addition to her presentation. So with those 2 small announcements, I hand over to Dr. Deepak Govil for moderating today's session. Thank you, Deepak.
Thank you, sir. I think it's a wonderful opportunity. And today we'll be talking about ulcerative colitis. As you all know, ulcerative colitis is mainly a medical disease. But I think when we consider moderate to severe ulcerative colitis or prolonged ulcerative colitis, then obviously it's a disease which requires multidisciplinary treatment and where gastroenterologists and surgeons come together. So I think we have a talk, we have a plan for today and tomorrow. The first talk, as Sir said, would be on medical management of ulcerative colitis by Dr. Venkataraman, Jayanthi Venkataraman. I would hand over to Dr. Jayanthi, please.
Good evening to one and all, and thank you, Dr. Kapoor, for inviting me to make this presentation today on medical management of ulcerative colitis. So in the next 12 to 15 minutes, I'll be covering this topic. And so the talk will include a brief introduction to the subject. Then I'll have 2 cases for discussion. And what are the drugs that are available based on the site of action, those conventional and those which are in the horizon, that is on advanced therapy, and which drug to use and for how long. And finally, go to a brief conclusion. So coming to a brief introduction, ulcerative colitis, as we all know, is a colonic disease. It's an idiopathic disease where the mucosa is involved along with the submucosa. It's a continuous disease starting from the rectum. There is friability of the mucosa. And most important, it is to remember that it is a lifelong disorder with a significant impact on physical and mental health. And what's also interesting and important to know that in India, the northern and eastern parts of the country have more of ulcerative colitis, whereas the southern states have more of Crohn's disease. So the primary goal of treatment, coming to the topic for presentation today, we have to discuss on what is induction and maintenance of remission in ulcerative colitis, which will be largely a clinical remission, endoscopic and histological remission, and to obtain a sustained and durable period of steroid-free remission and achieve a mucosal healing, that is resolution of inflammatory changes, getting a Mayo endoscopic subscore of 0 to 1. And finally, improve the patient quality of life, prevent physical disability, that is mainly ileostomy, a colectomy, or a progression to colorectal cancer. So the treatment selection is largely based on the Montreal classification, and this gives us an information on the extent of the disease, whether the disease is proctitis, left-sided colitis, or it's extensive colitis as designated by E1, E2, and E3. And the disease severity is essentially classified as mild, moderate, or severe based on the UCI scoring as well as the Mayo scoring. And practice guidelines as of today is largely either a step-up or a top-down procedure, largely based on the severity of the disease. Now, before we go to the evolution of the various therapeutic armamentarium that is available for management of these patients, just a brief overview on what is the pathogenesis or immunopathogenesis of inflammatory bowel disease. You can see here that in a normal, healthy colonic mucosa, we have a thin mucin layer. This is largely produced by the goblet cells of the colonic lining epithelium, and beneath that are the colonocytes. So the first defense mechanism of the colonic mucosa is the mucin, as well as the goblet cells, as well as the Paneth cells. In patients with inflammatory bowel disease, due to either a dysbiosis of the gut or due to inflammatory pathology, the mucin layer gets distorted and there's a leaky intercellular pathology, as a result of which there's leakage of the bacteria or the environmental factors into the lamina propria and the submucosa. What happens here is there are two important cells that participate in this inflammatory process. We have the dendritic cells and the mononuclear cells. Both of them are involved in the extensive cascade of immune-mediated responses, resulting in production of excessive cytokines as well as chemokines. So level 1 is disruption of surface mucosa. Then there's stimulation of the dendritic and the macrophage cells. These are two important cells that result in the cascade of inflammatory pathogenesis in IBD. There's stimulation of lymphocytes and neutrophils. This is the adaptive type of response. And you can see here the naive lymphocytes, they stimulate the helper cells 1, Th1, Th17, and Th2. These are the three important helper cells that are stimulated, resulting once again in large number of inflammatory response that is mediated by chemokines and cytokines. As a result of this, there's also involvement of the resulting in stromal degradation and destruction of the lining epithelial cells, resulting in apoptosis as well as a leaky membrane. So this is very important that we understand, because all the target cells you see here, Th1 results in interferon gamma, which stimulates the macrophage to present TNF-alpha. That's where the infliximab and all the biologicals act. Then we have other newer drugs that are now acting at these cytokine and chemokine levels. So this basic pathogenesis of immune-mediated pathology in IBD is very important. So over a period of time, there has been an evolution in the various drugs. Before 1930, we had no specific therapy for IBD. And then came in 1930 to 1940, where the aminosalicylates came into existence. There we have the sulfasalazine, the mesalamine, which are either oral, suppository, enema, or a foam preparation. In the 1950s, we had the corticosteroids, which are either systemic, or we have the local acting, the MMX budesonide, that is the multimatrix budesonide, and beclomethasone. And in 1960, we had the immunomodulators, azathioprine, 6-MP, methotrexate, and cyclosporin. And until this time, that is 1930 to 1960, these were, and even today, they constitute a major armamentarium in management of patients with IBD, along with the newer drugs that have come into the market. So the combination of conventional with existing therapy is the state of management in the present context. So almost 40 years, from 1930 years or so, we had these three drugs which we were using for management of patients with ulcerative colitis. In 1990 to 2010, we started getting the biologicals, which are essentially monoclonal antibodies. And what we use in our day-to-day practice is the infliximab and adalimumab. And from 2010 to 2023, we have the integrin antagonist, the interleukin antagonist, the Janus kinase inhibitors, and then the sphingosine 1-phosphate modulators. So these are the newer drugs which are now available in the market, and they're trying to make their best to use these drugs in management of our patients. So let us take the first case, a common case that one comes across in our day-to-day practice. A 36-year-old male with history of bloody diarrhea since mid-2023, passing 3 to 4 times per day with nocturnal symptoms, with abdominal cramps and tenesmus, which is very classical of an ulcerative colitis. The tenesmus and incomplete evacuation is very classical of IBD. And this patient was afebrile. There were no systemic symptoms, and except for a mild pallor. The lab investigations revealed anemia and a thrombocytosis. Stools were negative for parasites and cultures. And based on True-Lovett's criteria, the patient was in the category of a mild ulcerative colitis. So colonoscopy, we always do a limited colonoscopy during the acute phase without a preparation. We saw an inflamed mucosa with loss of vascular pattern and mild granularity and friability of the mucosa. And this constituted a Mayo score of 1 and a UCI score of 1 to 3, which is actually a mild colitis. And the biopsy confirmed that this patient had ulcerative colitis based on cryptitis and crypt distortion and goblet cell depletion. So this patient, based on the Montreal classification, belonged to E2. It was left-sided colitis with mild ulcerative colitis. Patient was started on mesalamine suppository. That's the first line of management, along with 800 milligram 3 times a day, constituting 2.4 grams of mesalamine per day. And this is the preferred dose in an acute state. We don't start with an OD dose. We always start with a divided dose in an acute state because of the intestinal hurry. Over a period of 2 weeks, the frequency subsided and the patient was continued on treatment for the next 12 weeks until remission. What is very important is that this patient should be counseled that he does need a long-term maintenance, and over a period of time, one can stop the suppository, but one has to continue with the oral medication. So what is the site of action of these ASA and glucocorticoid preparations, which are the level 1 conventional treatment options for management of ulcerative colitis? The ASA acts on the surface of the mucosa, and it is actually acts on the pro-inflammatory mediators, which are shown here, and as well as the glucocorticoids, which act at the various interleukin levels. The ones that are marked with cross are the sites where the glucocorticoids act. So this is a mechanism of action. The action for azathioprine is largely complex, and it involves multiple systems, which is yet not clear, but it is a good immunomodulator for management of patients with mild ulcerative colitis. So the choice of drugs in mild to moderate ulcerative colitis for E1, that is rectal involvement, ASA, both for left-sided extensive, ASA topical or oral plus topical, depending on the extent of disease, is the choice of drug. When they do not respond, one can include the installation of local steroids. The maintenance is always with an ASA preparation. Steroid is never recommended for maintenance of remission. I think this is also very important that one should remember. In case the patient, they do not respond to the ASA preparation, we move on to systemic steroids. And even if they do not respond to them, then comes the use of biologics. So the maintenance in such situations would be immunomodulator will be the main drug which is used for maintenance, and across all, that is both proctitis, left-sided colitis, as well as pancolitis. To take a second situation, this is a 28-year-old lady who reached UK soon after marriage and had a sudden onset of bloody diarrhea within 3 months of arrival. And this was almost 15 to 20 times a day, very severe form of disease. She was very sick. She was managed initially with IV steroids, total parenteral nutrition, as well as PRCs. When there was no response on day 5, she was also started on infliximab on day 0, 2 weeks, and 4 weeks. And there was some improvement, but not significant, to the extent that she became so ill that she required a subtotal colectomy with an ileostomy. However, since the rectum was still intact, she continued to have bleeding per rectum, and the suppositories as well as the local installation of ASA preparation did not help her. So we waited actually because she was recently married. So in 2022, she did undergo a successful pregnancy, and in 2023, an option was given to her whether she would go for an ileopouch anal anastomosis All the points for and against were discussed, and she, however, preferred a permanent ileostomy because of the problems that was posed to her about the problem of the pouchitis. And now she's ready to travel back to Canada in the first week of March. So choice of drugs for moderate to severe ulcerative colitis, unlike patients with mild colitis, is now steroids with or without biologicals across the board, whether it is rectal, left-sided, or whether it is pancolitis. And in patients who are refractory either to the systemic steroids or to biologicals with or without immunomodulators, they are the ones where surgery is absolutely indicated in such patients. So amongst the newer drugs, I think this is very important that you understand here, the very first biologicals, the newer drugs that came into existence for the moderate to severe ulcerative colitis were the infliximab, which were the drugs of choice in management. We had the infliximab, and then came the adalimumab, and they are the ones that were the first drugs to be introduced. And this is largely due to the increased production of TNF-alpha by the stimulated lymphocyte, that is T helper cells 17, 1, and 2. And these cells are actually coming from the blood vessel, and those are the ones that are getting activated during active inflammation. So these are the biologicals. They are monoclonal antibodies, and they act against the TNF-alpha. The second group are the alpha-4 beta-7 integrants. These are the drugs which are currently being used. They are anti-integrants and anti-leukocyte adhesions. That is the characteristics, and vedolizumab is the drug of choice. The third drug that came into existence are the anti-integrants. And here we have they act against the cytokines, and they are the drugs that are being marketed in the present days. And JAK kinase is a new kid on the block, where we have the tofacitinib and filgotinib and upadacitinib. All these are in the trial, but tofacitinib is making a major breakthrough in management of patients because it reduces almost all the pro-inflammatory cytokines and chemokines. And the most recent and the most latest is the one that acts on the lymph node, where you have the sphingosine 1 phosphate modulator. They retain the lymphocyte. So once they retain the lymphocyte, the entire cascade of lymphocyte-mediated cytokine and chemokine-mediated inflammatory response is likely to be abolished. So currently, the role of biologicals and newer molecules will be in induction as well as for maintenance of remission in patients with moderate to severe ulcerative colitis. And many of the times now, we are able to maintain all these patients also with some of these drugs. However, patients with the infliximab and adalimumab may require therapeutic drug monitoring, as over a period of time, there can be a loss of response, especially with infliximab. I would like to mention a few points on tofacitinib, which is now becoming an upfront drug in managing patients with acute severe ulcerative colitis. It is a non-biological small molecule agent. It is not a monoclonal antibody, and therefore it has no immunogenicity. It's rapidly absorbed, available as oral preparation, rapidly eliminated, has a very short half-life of 3 hours, and it has a dual benefit of quick effectiveness and quick elimination. So that's a major advantage of tofacitinib. The low cost and important therapy, especially for us in these countries where it is a low and middle income countries, it is affordable as a drug of choice in management of these patients. So current indications for the JAK inhibitors are both for induction and maintenance of moderate to severe naive ulcerative colitis, especially now, currently, we are using it when there's a standard conventional or biological therapies fail, but more recently, the drug is even being used as upfront as the first drug of choice for managing these patients. It also seems to have a role in extraintestinal manifestations like arthritis, ankylosing spondylitis, ocular, and other skin manifestations. The contraindications for tofacitinib are during pregnancy, elderly, breastfeeding, and patients with venous thromboembolism. Adverse effects are infection, most important being the herpes zoster infection and tuberculosis and venous thromboembolism. So in India, there was a recent publication, which is actually online, multi-center study where they had 47 cases, and they found that at 8 weeks, tofacitinib caused a clinical remission of 70% and maintained at 6 months to the tune of 60%. And the independent predictor for remission of tofacitinib was the baseline serum albumin. Low albumin resulted in a poor response. And adverse effects in this particular study was essentially tuberculosis, CMV colitis. They were all less than 2%, herpes zoster, and mania. There was one other study which looked into the post-surgical outcomes in patients who were on tofacitinib, and they did find that a small percentage did have venous thromboembolism as well as post-surgical infections. So to summarize, if you have a patient with mild ulcerative colitis, the choice of drug, as I said, would be mesalamine, 1 to 4 grams per day. If there's a response, we maintain on the same drug with the same dosage that was used for induction, or if there's no response, these patients are switched over to oral corticosteroids. If there's an extensive disease, that is E3, almost pancolitis, the choice of drug remains the same. There may be a role for budesonide, multi-matrix component in a dose of 9 milligrams per day. And patients with moderate to severe ulcerative colitis, these are the patients, steroids would have a major role. If there is no response, these are the patients who would require infliximab or adalimumab in combination with the immunomodulator, that is azathioprine. So in a nutshell, mild disease, mesalamine preparations, whereas in patient moderate to severe, they are the ones who may require steroid systemic or otherwise in combination with biologicals as well as infliximab, that is with immunomodulators. Those with severe ulcerative colitis will require hospitalization, and they will require the IV hydrocortisone that is given at 100 milligrams to 3 times a day. And one would look for a response on day 3 to 5. During this period of time, all the other supportive management would be looked after. There will also be a minimal sigmoidoscopy to exclude a CMV infection. Stool cultures would be done. And one would always avoid anticholinergic or narcotic drugs. At the end of 3 to 5 days, if there is a response, then these patients are started on azathioprine along with mesalamine. However, if there's no response, they are the ones who would either require infliximab or a cyclosporin as an alternative, and they are maintained with the cyclosporin or infliximab along with an immunomodulator. Those who are refractory to either of this treatment are the ones that would go for surgery. So ultimately, the aim of management of patients or medical management of patients with ulcerative colitis is to obtain a mucosal remission. So if the patient has active disease, surveillance should be done at 3 to 6 months interval. If it is in remission, it is at 6 to 12 months. And what we're looking for is remission targets by normalization of the clinical presentation, for mucosal healing with the endoscopic scores, and adjunctive biomarkers such as fecal calprotectin, so that we're able to achieve a complete mucosal healing in patients with ulcerative colitis. So last word on preventive management. All patients with ulcerative colitis should be screened for depression and anxiety, as they are patients on steroids. Women with ulcerative colitis are at high risk for cervical cancer, and especially those on thiopurines, and therefore they may need the papillomavirus vaccination. Screening for skin malignancies should be screened periodically, especially those on immunomodulators. Bone mineral density should also be checked, and they should be supplemented with vitamin D and calcium. And for the vaccination, in our day-to-day practice, we are actually giving them pneumococcal vaccine and influenza vaccination and hepatitis B vaccination. Herpes zoster vaccine, I think, has just appeared in the market, and some of the patients, my colleagues, have used this as a protective means in patients with ulcerative colitis. So I would like to conclude by saying that while we have huge amounts of biologics and newer therapeutic armamentarium that is available to us for management, other advances are taking place in therapeutic modalities, and these include the stem cell transplantation, fecal microbiota transplant, and these are actually therapies that are directed against the dysbiosis. However, we do not have much information on who should be the donor, the various delivery systems that needs to be opted in these patients, what should be the duration of treatment, what will be the endpoint. All these are not yet known to us. And finally, with artificial intelligence coming all along for many of the medical disorders, I think there may be a role for this as well in management of our patients. So are we heading towards a cure for ulcerative colitis? I think not as yet, because despite the availability of so many drug options, we find that we're not able to still identify the right treatment for the right patient at the right time. And outcome of any regimen that you see, whatever be the drug, whether it's infliximab or vedolizumab or any of the newer drugs, including tofacitinib, the outcome is just about 30 to 40%. Except tofacitinib is now showing a response to about 60 to 70%. Safety of long-term use of any of these drugs is not yet established, so we still do not know where we are, and whether the novel treatment can improve the lives of the patients remains unanswered. But I think despite all this that we have discussed today on medical management, I think after one important thing, I always feel that when the patient is too sick, I think to me it would be that give them an option for surgery at the right time so that they have a good quality of life. Because of the number of cytokines and chemokines acting at different levels in the pathway of immunopathogenesis of ulcerative colitis, we are still not able to find biomarkers which can target at any particular site to give a cure to our patients. I think with that, I'll conclude and probably take up some questions for discussion. Thank you.
Deepak.
Yeah. Thank you. Thank you. Thank you, Dr. Jayanthi. I think wonderful display of all the aspects of medical management. I think are there any questions from the audience? You can all write in the chat box if there are any queries you want to answer. There are a few things I would like to highlight and ask Dr. Jayanthi. One is you said step up or top down approach. In that, in which cases would you go for which approach usually? Usually it's a step up approach, and top down do you use in some patients?
In ulcerative colitis, it's usually step up, sir, especially the mild and the moderate ones. In severe colitis, those are the patients where we may consider, but even now, the first level one is IV steroids. And then when steroids do not work, then we add the biologicals. In that, the choice of drug is infliximab as of now. Along with, later on we followed with a immunomodulator. So top down is more for Crohn's disease, but ulcerative colitis still seems to be a step up approach. But tofacitinib, the All India Institute of Medical Sciences, they are using that as upfront in patients with acute severe ulcerative colitis, and they find a dramatic response, real dramatic responses. That paper is yet to be published, and they feel that it may be one of the first drug of choice not going through the steroid pathway. So that paper is yet to be published by Vineet Ahuja. So that's awaited.
Right. Right. In this acute severe ulcerative colitis, as you said, that after 3 to 5 days of steroids, you would go in for infliximab and other treatment before going in for surgery. How long would you wait with these treatments before you consider a surgical intervention?
So when I see a patient with acute severe who's severely toxic, I get the surgical team in first. In fact, few patients, we've even had a immediate ileostomy to first relieve the problems related to acute severe colitis, and then take a call as to what is to be done. Because once steroids are given, then surgeons also have a difficulty in managing these patients. So in acute severe, I move in the surgeon, and then we decide as to what should be done for a patient. Basically, they'll be able to guide us whether to continue and wait, or based on that clinical, it will be more like a personalized medicine at that stage.
I think we have Sujoy also with us. Sujoy, could you like this tofacitinib? If there's anything which you can...
I don't have the formal idea about this study, because right now, as far as I know, we are still doing colectomies very commonly, almost 2 or 3 times a week for all the so-called failures. But yes, there have been changes in the constitution of the patients over the time. In the past, about a decade back, it was only steroid failure. Now, of course, you have multiple attempts at, treating them, and sometimes it gets delayed because of that, and then we land up with problems also. So that has happened.
Any other queries or questions, sir?
Can I? So, Dr. Jayanthi, 2 things from the point of view of students. One is that they are often asked the same question which Deepak asked, that suppose there is a patient with acute severe ulcerative colitis, and we started the patient on IV steroids. Now, is it the number of days that you wait, or is it the response? So suppose the patient Suppose the patient is responding, can we wait for more than 3, 5, 7 days? And if the patient is not responding, should we go in or should we change the management earlier?
So if at 3 to this is basically the Oxford criteria, Travis criteria. So by 3 to 5 days, we find that there is a significant response. Systemic symptoms come down, frequency of the motion is also coming down. Then yes, I think I would proceed for that. Proceed for a medical line of treatment. But at some point of time, this particular person is going to land up with a colectomy at some point. So maybe this will act as a bridge for planning for a colectomy at a later stage. And with the availability of the biologics, there are some patients who have moved around, say, for next 2 or 3 years. But if they have frequent relapses, I think that's the time when they will land up with problem. But if they're not responding on day 3 to 5 and they're still worsening, I think that will be the endpoint and take the patient for surgery.
Second question is the issue of tuberculosis and biologicals.
So all these patients require a screening for latent tuberculosis, sir. We have the IGRA assay, we have the, all patients should have a CT chest. So CT chest is a must. Of course, then we have the IGRA test and then we have the MAN2 test. And we screen these patients and ensure that tuberculosis is not there. If there's any doubt, then we put them on a prophylaxis and then combine. But I've had experiences of my own of patients who had very florid tuberculosis with the introduction of infliximab. They're all immunosuppressants. So screening, CT chest is more important than an X-ray chest. I think that's the answer that the examiners would want for the screening of the tuberculosis.
And the vaccination schedule which you showed is only for tofacitinib or is it for all biologics?
No, for all. It is for all patients who are presenting with IBD, whether it's Crohn's or ulcerative colitis. What we recommend is definitely hepatitis B, because they can have a flare, pneumococcal vaccination, as well as the influenza vaccination. Herpes mainly for the tofacitinib. Tofacitinib is more for herpes.
Okay. Thank you. Thank you. Deepak, please carry on.
Dr. Jayanthi, one thing I just wanted to know, what are your objective criteria of referring a patient to a surgeon and a patient with a long-standing ulcerative colitis? And have these criteria changed over the once these biologicals are there
now? I think earlier, maybe in 1990s and early 2000s and all, when I was with Dr. Surendran at Stanley Hospital, all patients with severe ulcerative colitis, he would say, why are you making the patient suffer? And he would go for a colectomy, subtotal colectomy. So those days we didn't have biologicals. But now with the biologicals in the scenario, the number of cases being referred is less. But I think most important is for the physicians to pick up those small percentage of patients who are really critically ill. And who are really and we are helpless as physicians, and that should be the case that should be referred. And ileostomy, I feel, is a simple procedure to tide over the immediate situation and then go for a second stage surgery and then a third stage. So I think it is discussion with the physician and the surgeon. Surgeon and physician I always believe in that. I've always been having a close liaison with surgeons. So I'll always have a talk with them, then talk with the patient, and then take a call.
Yeah, I think that's very important thing you pointed out, that it's a combined decision, and especially for acute severe ulcerative colitis. But I just wanted to know about the chronic ulcerative colitis. At what stage? Like if there is a young patient, 20, 30 years old, with a pan-severe colitis, when would you consider a surgical intervention in such a patient?
So in such patients, I have few patients who've been with me for 10 years who had pancolitis. They're all okay. They're all okay. They're on small dose of mesalamine and they're okay. But they started off as severe, but not very severe. But they were managed, and we could manage them with mesalamine. So the chronic ones usually, except those who are followed up with surveillance for high-grade dysplasia, and those are the ones who will go definitely for colectomy. So they're on a strict surveillance. After 8 years, they're on a strict surveillance, at least with a CEA, with a colonoscopy done periodically, to look for any dysplasia, especially with the NBIs and all, high-grade dysplasias and all. If there's any doubt, then we push in for a colectomy. Otherwise, most of the chronic ones don't have such severe flare. It burns out. The colon burns out. So they settle down. It's actually like, it's just like a pipe stem, the colon. So they don't really have those severe flares. The initial flares are very severe. Subsequent are all mild. They just have 8 to 10, 5 to 10. We're able to salvage them with medication. And those on infliximab, they're not able to continue for more than 3 doses because of the cost. But what we say, at least give them the 3 doses and continue with azathioprine. Again, those are the patients who do not respond, may land up with a colectomy. those who are having troublesome due to economic constraints, they're not able to get the medication, they're still suffering. I think they are the definite cases who require, especially in, say, in the public sector, government hospitals and all those patients are not covered by any insurance or anything. Those patients are the ones who really be pushing for a surgery rather than making them take all these drugs which are not available to them. They default on adherence and therefore they have repeated flares.
Roughly the cost of biologicals which are commonly used, are they easily affordable?
More than a lakh, sir. It comes to about, I think each dose is about 18,000, 20,000. So in a month or so, it costs about 1.5 lakh, and every 8 weeks they have to take infliximab.
Yeah.
And we have all the problems. If they don't respond, again, we have to check the therapeutic monitoring. We have to see whether the dose is adequate. Now, this is available in very few centers. All these problems are related to that medication. So biologicals to me is always quite scary in managing such cases.
I think one of the important points you've made is that it's a combined decision usually, especially in acute severe ulcerative colitis. And even in prolonged ulcerative colitis, when you have to shift to biologicals, you have to see a lot of factors and you have to individualize the treatment and customize the treatment according to the affordability of the patient, the extent of the disease. And I think we should have a combined meeting, especially with such patients, and then decide the treatment rather than just going on to biologicals.
The problem is the severe proctitis, no? Severe proctitis not responding, whether to go for a colectomy. That's always one confusion there, left-sided. So there's nothing called a subtotal, can't do left-sided colectomy, such patients. The disease is progressive. So those are I've not had such patients. Most of them respond. Most of them do respond to the local enemas and foams and all that. But occasional cases like this lady, she continued to bleed from the rectum. She continued. Mm-hmm. So she said, I'm happy with that. You just do a mucosectomy, remove this thing, and she's got a stump closure. She's happy with the ileostomy because she's worried about the pouchitis, which was discussed with her. So the question is, I think the surgeons will answer that. The proctitis and the left-sided colitis, which is severe, not getting controlled, should we go for a total colectomy? So that is something that they always ask. For such a short disease, should I undergo surgery? And maybe these are the ones who will do well with biologicals, tofacitinib and other drugs. Because proctosigmoiditis still remains the most common site. Pancolitis, just about 1 to 2%. We don't see that many cases. At least in down south, it's very uncommon. That's what I said. North and eastern parts of the country, ulcerative colitis is dominant. Down south is mainly Crohn's. So we don't see those severe forms we do see, but very occasionally. Not so common.
Let's move on, Deepak.
Like surgeon was telling, he does 2-3 colectomies in a week. So that means it is really rampant up north. So thank you so much, sir, for this opportunity. Thank you.
Thank you, Dr. Jayanthi.